Good morning and welcome to the Chest, Heart and Stroke Scotland No Life Half Lived webinar. It's really lovely to see you all here this morning, and I just want to say thank you for taking the time to come along and to take time out your busy schedules for joining us. My name is Lindsay Duncan and I am the Deputy Head of Clinical Services with Chest, Heart and Stroke Scotland, and I will be your host for this morning's webinar. So today we're going to hear from our CEO, Jane Claire Judson, about our No Life Half Lived 23 to 28 strategy. And we'll also hear from Chris in our services team about our community healthcare model of support. And we'll also share feedback from professionals who we work in partnership with here in Chest, Heart and Stroke Scotland. But before we start, I would like to review some housekeeping rules with you. We will put your microphones on mute during our speakers' presentations and during our video content. However, I would like to remind you that you do have the chat function that you can post questions or discussion points into. We will have 2 question and answer sessions this morning where you will have the opportunity to either ask questions through the chat function or we will unmute your microphones so that you can ask questions in person. But before we start this morning, I want to make sure that everyone's fresh and paying attention and do a wee bit of interaction with you just to get started. So we're going to do a short quiz, and this quiz is based around our No Life Half Lived strategy and our 1 in 5 research report that we published last year. There are 4 questions, and the good news for you is that the responses will be anonymous. You will see the questions pop up on the screen, and if you just take a minute to select what you believe to be the correct answer, and then we'll move on to the next question. So how many people in Scotland are living with chest, heart, stroke or long COVID conditions? And the answer is B, 1 in 5. Question 2, what percentage of people with a chest, heart and stroke condition say that they have accessed formal rehabilitation? And the answer is C, 45%. Question 3, how many people in Scotland are living with long COVID? And the answer is 180,000, so A. And the final question is how many people with a chest, heart, stroke or long COVID condition say that it impacts on their mental well-being? And the answer is C, 2 in 5. So thank you for taking time to click your responses and for that wee interactive session. And we will do another interactive quiz towards the end of the webinar this morning. I would now like to share a video with you where you will hear from partners that we are currently working with and who've kindly agreed to share their feedback with you this morning. So I'd like to extend thanks to Dr. Gurab and to Heather for giving us that feedback and for taking the time to create the video. And I hope that that gives you some insight as to the experience and feedback of working in partnership with us as an organisation. I would now like to welcome our Chief Executive, Jane Claire Judson. And Jane Claire's going to talk through our new No Life Half-Lived strategy for 2023 to 2028. So I'll hand you over to Jane Claire now.
Thank you so much, and thank you to all of you for coming along this morning. I'm really aware of the pressures in the NHS at the moment, how difficult it is to sometimes take time away from these roles that you're in across the country. So I just want to say that I really appreciate the fact that you've managed to come along this morning, and hopefully as a result of this we can do more work together to release the pressures on the NHS and to support people with our conditions. So as the Chief Executive of Chest, Heart and Stroke Scotland, it's an amazing charity to work for and an amazing role to be in. We have a fantastic mission, which is to reach the 1 in 5 people with our conditions across Scotland, but we absolutely can't do that alone. We have to do it in partnership, we have to do it in working collaboratively together, and it was brilliant to see those films, and I genuinely hope there's some new partnerships that can be built from those of you who've attended this morning and are in the room with us. So thank you very much for coming along. In terms of our strategy, I'm going to take you back. First of all, in 2018, we launched No Life Half-Lived for the first time. At a time when we didn't know that there was going to be a global pandemic and various economic crises. So we were very ambitious for our strategy and very hopeful about what we could achieve. And in terms of doing that, we set ourselves some targets. And I'm conscious that certainly within the health service, targets are quite often a touchy subject for all of us to have a look at, but also that we do like a bit of data and a bit of performance related data. So I thought that I would share with you this morning how it was that we did against our original strategy from 2018. So we set ourselves 3 very, it seemed simple targets, but obviously were much more complex in their actual delivery. The first one was to double our reach. As I mentioned, that 1 in 5 people with our conditions across Scotland, that's a huge number to reach, and we felt as a charity we could be doing a lot more and reaching many more people. So we set ourselves a target to double our reach. As a result of that target, we knew that we'd have to then increase the number of people who could work with people with our conditions. So we said that we'd double the number of volunteers that we recruited to the organisation in order to support us to do that. And volunteering is really core to what we do at Chest, Heart and Stroke Scotland. We're one of Scotland's largest volunteering organisations, and the value, the skill sets and the insight that volunteers bring to us is really invaluable to us and to our service users. And of course, to do both of those things, we needed money. Money is something that we all need. We all need our budgets. We all need our financing to be able to deliver what we want to do. So we said that we would also increase our income. We'd double our income at the same time as doubling everything else. Now, I have to say, over the past 5 years, many things have happened. There's been many challenges and barriers along the way, not least the COVID pandemic. But I'm really proud to say that we did manage to double our reach as an organisation. You can see that lovely magenta circle there. It's really lovely to see 100% reach target for anything that you try to do and achieve. And alongside that, we did double the number of volunteers. In fact, we totally smashed that target. We more than doubled the number of volunteers that work with us in the charity. The income one, as you can imagine, was just a wee bit more of a challenge for us. It certainly wasn't one as we moved into 2020 that we were going to reach. But what I can say is that in lieu of being able to double the income, what we did look at doing is making sure that every pound worked as hard for us as we could make it work. And one of the things I'm incredibly proud of is that we managed to increase the amount of money in the pound spent in the charity directly to our services from 70% to 88%. So looking at our costs, looking at our efficiency and our effectiveness, making sure that we made really good strategic decisions, we've managed to make sure that as much income as possible goes towards our services. And I think in straitened financial times, the ability to do that is really critical to us as an organisation. And also to show to everybody on the call that we're a good bet. You know, we're an organisation that you can rely on. We stick to the targets that we set, but also we use money wisely. And as we know at the moment, that is a really critical priority, both within the NHS and the third sector. In terms of just looking at those achievements across the 5 years, there's just a couple of things I wanted to pick up. I've already mentioned the 88% in terms of charitable spend. I also want to mention that we launched our hospital to home service, in some ways very much the precursor and the foundation for what it is that we're talking about today. So looking at how it is that we reach people after that acute moment, that blue light moment or diagnosis moment, where people come home and they have to then think about the rest of their lives and how they're going to cope with a condition that they've either just acquired or perhaps they've maybe suspected for a while, but they've now had that final diagnosis and they need to get to grips with that. And I think that bridging between clinic, between hospital, between the care within the NHS, into community and into people's homes is really what we're about as an organisation, is making sure that nobody feels left behind and that nobody feels alone. And certainly, you know, if the pandemic taught us anything, it's that feeling isolated and lonely has such an impact on people and such an impact on their health and well-being. And being able to deliver services to people with our conditions to make sure they don't feel that is really critical to what we do. I also just want to mention the fact that, you know, we over the last 5 years, we have raised £55 million. It's not an insignificant amount of money. And that is money that can be invested in supporting people with chest, heart, stroke and long COVID conditions. So there's a real offer there over the next 5 years around having that ballast behind us to be able to invest in services and to be able to take things forward in our communities and to make sure that we create that investment for the long term and ensure that it is sustainable. So you will be familiar with many of these numbers. There's such a fantastic diversity of people on the call today, but a lot of you will recognise these numbers from the various different roles that you have within the health service. The key one for us, though, is that the 1 in 5. 1 in 5 people have our conditions in Scotland. And that means that even if you don't have one of our conditions yourself, you will know someone who does. It will be somebody in your family or your circle of friends or your colleagues. They'll be experiencing one of our conditions. So it is a Scotland-wide challenge and a Scotland-wide issue to tackle and to make sure that everybody that we work with, that we live with and that we love has that support with living with our conditions. Of course, one of the things that I always find really interesting about these figures is just the number of people who are undiagnosed. People who are walking about with a condition that they haven't been given the chance to manage. They haven't been given the chance to learn about and to be able to manage their risks and their symptoms and perhaps prevent an acute event for themselves or at least delay some of the issues that come alongside our conditions. One of the things that's really important as an organisation is to listen to what people with our conditions feel, how they experience life, how they experience their condition, and also how they experience us as a charity and the delivery of our services. And here's some quotes from people that were fed back to us during the work that we did to refresh our strategy. And I guess the kind of real message here is about that kind of anxiousness and that worry, a little bit of fear in there, and the idea that people need a bit more information. And that sometimes people actually wish they'd known about us as a charity. They wish they'd known that there was somebody there at the end of a phone or in a peer support group in our communities who could have supported them at this point in their lives. And that's really a message that we've brought through our whole new strategy, is that sense of making sure we understand the pinch points for people and where it is they really need the help and support. And in terms of looking at that, we carried out Scotland's largest survey of people with our conditions last year. Over 1,800 people were surveyed and another 40 people we engaged with much more directly on a one-to-one basis. And the results from this are both startling, but also give us real insight to build on and to be able to design services and design pathways to make sure that people are supported. So a really key thing for us here was looking at the data around supported self-management and what it is that people get access to once they're home or once they're back in their own community. And what became really clear throughout this process, and I'll be honest, I didn't expect this result. It was as much a shock to us as it might be to those of you on the call this morning, is that more than half of people in Scotland with our conditions just don't get referred for rehabilitation. They just don't get referred on to a service or a support mechanism that helps them to understand their condition and to live well with it. And I'll put a caveat with that, because we do know that the people that do access rehabilitation rate it. You know, we never hear someone say, "Oh, I really wish that I hadn't had that rehabilitation programme that was delivered in my local health board." We don't tend to hear that as a piece of feedback. But what we do hear is from the people who don't receive that support, and how much that impacts in their life and how it affects them both physically and mentally in terms of how they then manage their life and manage their condition. I think it's also really important that we know that 1 in 3 people are living with more than one of our conditions. So quite often it's not just one challenge that somebody has, it's a multiple challenge that they might have in their lives. And so making sure that services acknowledge that, that they're integrated, and that we understand the whole person, I think is critically important, both for the NHS, but also for us as a charity. And sometimes it might be us that draws those strings together for somebody and pulls that together to make sure they get that whole system and rounded approach. Of course, the final thing that was really critical to us as an organisation is, does what we do matter? what's the point in Chest, Heart and Stroke Scotland existing if we're not having an impact? And so what we did find out through our survey is that people supported by us rated their health and well-being higher than those who didn't get our support. And that's critical. That means that we can deliver something really tangible to people with our conditions, but it also means we can deliver something tangible for our health services. That if you work with us in partnership, if we have referral pathways in place, we know that we can deliver benefit to the patients that you see. I always really kind of feel for healthcare professionals in terms of you do such a fantastic job under really tough circumstances and pressures. You have such an amazing skill set, amazing experience and skills to take forward with people with our conditions. But then I always wonder whether people who receive that care are able to get the best value out of it once they leave your care and move back into their home and into their community. Do we manage to exploit as much of that as possible? And so we want to make sure that everything that you do on a daily basis within the NHS has the biggest bang for its buck and the biggest impact for people with our conditions as they start to move out of that kind of care and that safety of the NHS back into their daily lives. We think that's critically important and that we have a part to play in that. So here we've got a quote from Alison, who I think really clearly sets out why it is that Chest, Heart and Stroke Scotland can really deliver on these sorts of issues, and also why it's really important to people with our conditions. So she talks about where she started from and that she thought that she would never recover. And then in working with us, she managed to not just recover more, but recover more than she ever really thought she could. She had that sort of sense that she could do a bit more recovery. But what we're able to do is to add that value to somebody's life and to make sure that they can really maximise their recovery and really achieve no life half lived. I guess one of the things that we can do is the time that we can spend with someone. I totally understand that within the NHS, it's really hard for you sometimes to spend the amount of time that you would like. And I really feel for you on that. It must be really hard to be in a caring role, that support role, and to not necessarily always be able to spend as much time as you'd like with each patient. But we can provide that and to make sure that people have the time and space to develop their recovery over many years and to support them to get the best that they can out of that recovery and out of their lives. So here are some quotes about our services and how it is that our stakeholders feel about them. It was really important to us to reach out to our stakeholders as part of refreshing the strategy to understand that. And it was really lovely to get some of this feedback around, the fact that we were able to demonstrate the value of the voluntary sector in terms of supporting people with our conditions, that people find us a positive partner to work with. That's really critical. Partnership isn't always easy. It's always kind of challenging in terms of things like everything from budgets right the way through to shared goals and the pressures that change over time for organisations like ourselves and also for our NHS partners. And it was absolutely brilliant to see that people really valued that. One of the phrases I did really like is, I just think they've always been a really good ally. And if there's anything that you take away from today, it's to know that Chest, Heart and Stroke Scotland is your ally in all of this. We're a friend and a support to everything that you're doing in the NHS, and hopefully we can play our part as people move out of the NHS and into their homes and community. And that's really clear for us as a priority. It's also really important to us, though, to have constructively critical friends. And it's not often that you show your report card out to wider than your own organisation. But I think it's really important that we're really upfront and honest and say we don't always get it right. Sometimes we need to develop things and refine them. We need to take feedback from people, both service users or volunteers, and of course, healthcare professional colleagues, and understand what we're doing well and what we're not doing so well. So in 2018, when we launched No Life Half Lived, we understood that we were taking on something huge and it was a lot of work to do. And the feedback really is around that refinement as part of No Life Half Lived Mark II. And that's really the feedback that we're getting here. We have to decide what it is that we want to do and really focus on it. A huge amount of feedback that rehabilitation and supported self-management space is what everybody is wanting and willing us to do. They would like us to focus on that. And also to feed into the wider movements and the wider discussions about health policy in Scotland. So these are sorts of things that we took on board as part of the refresh of our strategy. And I hope that in our new strategy, you can see that we have listened to that. And it's really important that we do that and we learn from the feedback that we get. And certainly any feedback that you've got from today will be really welcome, because it's an iterative process. It's not a one-off listening exercise. We need to make sure that we're doing this on a regular basis to keep ourselves on track. So what does this all add up to? Now, it might be, I don't know what kind of screens you're all looking at. So it might be that the detail on this slide is a wee bit challenging to see. And it's really great that we've got Chris here because he's going to take you through much more detail specifically about our community healthcare support service model later on in this webinar. But this diagram really puts on one page what Chest, Heart and Stroke Scotland is all about for the next 5 years. So you can see our circle here representing all of our conditions. It's a challenging environment to represent all of these different condition areas. But one of the things that's really clear is how overlapping they are in terms of how people experience those conditions in their daily lives, the worries that they have about feeling isolated, about feeling lonely, that fear, that sense of, do I know what I'm doing with my condition? When do I phone the doctor or the nurse? When do I get back in touch with the NHS? Or when is it I just need a bit of help from the Chest, Heart and Stroke Scotland advice line or the services that they have? So that circle kind of represents that complexity there. The middle piece is the most important piece of our strategy, which is that our focus will be squarely in trying to close that gap of supported self-management and community support. We need to reach that 500,000 people that are currently not getting that support, but know that they need it and could benefit from it. And the 4 stages there really set out the key areas that we'd focus on in that. So the prehab and prevention space is obviously really heightened at the moment. How do we stop people either getting conditions or that we reduce the risks, the risk factors for those conditions, and also that when people know that they are experiencing those risks and symptoms, they know where to go and where to get help. And then, of course, there's the acute event, the blue light moment sometimes for people if they have a stroke or a heart attack, but sometimes it's not that. Sometimes it's a much longer pathway towards a diagnosis, and making sure that people understand what that means for them, that they get access to the right care at the right time, but they know that as they come out of that diagnosis, that Chest, Heart and Stroke Scotland is there for them. The most important bit, though, probably is at that home and in your community piece. That's where we can really excel for yourselves as healthcare professionals. We can make sure that people have that support both in a structured way, and we mentioned an 8-week supported self-management course within that area, but also with all of the different types of work that can happen with an individual to make sure that they understand their condition and what it is they need to do to achieve their own goals. And as you'll know as healthcare professionals, sometimes an individual's goals don't quite match clinical ones all the time. And working with people to make sure they reach the clinical goals, but also reach the goals that they have in their own life, I think is really critical. I always think of the person who comes home and their love is gardening, or their love is going to the football at the weekend, or the thing that really makes them get up in the morning, and suddenly they find that that's been taken away and they can't achieve it in the same way. And a lot of the work that we do is to make sure that those goals are met for someone, that they can manage to get back some of their old life, but also look forward to a new life, and to make that the most positive experience that they can. And then there's growing the chain of support. And in a sense, today is growing the chain of support. All of you who've come along today have shown a willingness and a warmth towards us. You know, you've given up your time, and growing the number of people who are involved in this and can help us to deliver it is absolutely critical to the strategy. We just can't do it alone. We can't reach 500,000 people on our TOD. We need to do that with amazing colleagues who've got the skills and the experience that we don't have, and that we bring that together to create something that's bigger than its individual parts. And that is really critical to us. Down that far side, there's a list of things that we're going to do as an organisation to help us achieve that. The middle piece can't be achieved on its own. So we do want to measure that gap. There's a real lack of data in Scotland about supported self-management and community. So we need to tackle that. We need to campaign for a right to rehab. Some of you will be aware of that campaign already in terms of making sure that the Human Rights Bill, which is making its way through all of the political processes right now, recognises the right to rehabilitation. That will give us leverage to make sure that we can then design services around that, to increase our reach, which is absolutely critical to us, to make sure more people know about us, but also know about all of the other services that they can access and have as part of helping them deliver that package for their life. To tailor things, to make sure that the individual feels that they're seen in amongst that. So it's always very difficult to try to take models and then apply them to individuals. That's really, really hard. You know, care pathways look great on paper, but then you meet humans, and we're all different, and we all require different things and different approaches. But making sure that we can kind of meld those two things together. So take the best of consistency, but then make sure it can be personalised at the same time is a real goal for us. And then to connect, to make sure that we're connecting with the right people at the right time, to make sure that we're making sure that people with our conditions can do that, and to build those relationships to deliver for the 1 in 5 in Scotland. So the impact that we would like to see is to fully understand the evidence and data around that rehab and around that supported self-management. And what we really want to do is to put some hard figures on it. Let's put some targets around it. is to deliver our community healthcare support services directly to 50,000 people a year, and to 100,000 through self-directed engagement. Some people want to do it themselves. They want to find their own way through the pathway. And then 25,000 through partnerships and collaborations. Now, we've kind of broken it down that way, but if I'm being honest, it's probably partnerships and collaborations across that whole piece there, not just the specific 25, but we've given ourselves a target to make sure that we consider partnerships and collaborations and that we keep that high on our agenda and not become siloed ourselves as an individual organisation. So, as I've kind of said throughout, we want to work with you to provide better care for people in Scotland and to make sure the 1 in 5 get that supported self-management piece. There's just no way that we can do it on our own. And if I'm being honest, we don't want to do it on our own. It's much more fun doing it in partnership with people from across Scotland, across health boards, IGBs, third sector partners. We just launched our partnership with the SFA yesterday. If you told me 5 years ago we'd be doing that, I wouldn't have believed you. So there's things that can happen that are really innovative and different and allow us to reach out to much more people across Scotland to support them. And I have a couple of quotes here from Amy and David, two people that work with, one in primary and one in secondary care, about how it is that we've been able to help them in terms of their roles to deliver that. And that's really critical to us, is to make sure that that engagement, that partnership working is happening to deliver for the 1 in 5. So I just want to say thank you to you all again for your time this morning. That's a kind of whistle-stop tour around the strategy and what it is that we hope to achieve. But I know that if we all work together and we kind of share our ideas and our resources, then we're able to do that. And to really just to extend that offer to you. It might not be today, it might not be next week, but if at some point you think that we can work together to deliver this, we're absolutely there at the end of a phone, at the end of the email. Make sure that you let us know that you're willing to do that and to keep this conversation going. So thank you all very much.
Thank you, Jane Claire, and I hope you'll all agree that that was a real insightful session into our new strategy. Now, what I would like to share with you is some quotes from people who've accessed our services, because of course this is at the heart of what we do. So I would like to share 2 slides with quotes from people who have accessed our services and what it's meant to them. And I'll just give you a minute to read through the quotes that are on the slide. And the same again with the second slide, if you just read through the quotes. So I would like to say thank you to everyone who's provided feedback from us, and the insight from our service users' experiences is a real aspect and integral for our organisation to ensure that we provide person-centred and high-quality support. I would now like to share another video with you, and this video is again hearing from more of our partners that we currently work with and who are happy to share the benefits of working together to support the people who are affected by our conditions in Scotland. I'll play the video for the first couple of seconds and then I'll stop it and just check that you've all got sound, because I believe there was an issue with sound with the first video. Can everybody hear that okay? Yeah. So again, I would like to extend my thanks to Therese and to Neil for sharing their feedback and creating that video content to share with you this morning. So that's now taken us up to our first opportunity for any questions that you might have. We will unmute your microphones, and I would urge you to use the raised hand option in Teams if you would like to ask a question in person, and alternatively you can pop a question into the chat, and I'm happy to pose them this morning.
Just to say, I think we do have a question in the Q&A tab that's around speech and language therapy. I don't know if you might not be able to see that, Lindsay, if you've not got it on your screen, but I don't mind reading it out if you can't see it.
I've just got it up, Jane Claire, just now. So the first question we've got is from Laura Cunningham, and is, do Chest, Heart and Stroke Scotland currently employ a qualified registered speech and language therapist to provide full training to staff and volunteers with being able to confidently support patients, clients with communication difficulties? Thanks. So we have Jackie with us today, and I wonder if Jackie would be happy to answer that question.
I've put a wee message in the chat just as a response, Lindsay. It's Joanne here. But Laura, thanks for your question. I'll hand over to Jackie in a second. I've just popped a response on to say that no, we currently don't have a registered speech and language therapist that works with CHSS, but we do work closely with registered SLTs across the country, which helps advise and give us the best evidence base for our training. We also have a range of clinical advisors that are employed by CHSS, along with a full range of other healthcare professionals. I think, to be fair, probably an SLT is maybe one of the only healthcare professionals that we don't have employed. But yes, we work closely with Royal College of Speech and Language Therapists and others across the country to help advise us on that. Jackie, I don't know if there's anything else you wanted to add.
Yeah, I would just say that our communication support service within community support services is a very community-based one, and we try to complement therapy and provide that community-based support. So we've recently reviewed all of our service and our training and refreshed that, and we keep up to date with things through partnerships like the Aphasia Alliance, which has both clinical and voluntary sector partners. So that's a key aim of what we're trying to do, is to make sure that we provide the best community-based support through what we do in our volunteer and staff-run services. So I hope that's helpful. If you'd like to have a chat with me about anything, I'm always available, so happy to do that. So thank you.
Thank you, Jackie and Joanne. We've got two people who would like to ask a question. So first to raise their hand was Loretta Galloway. Loretta, would you like to ask your question?
Hey, hi, yeah, my name's Loretta. I work for an organisation called Unity. Now, we're a third sector. We have learning disability services and we provide carer support services. I think what I'd like to ask is about the resources you have available for adults who've got a learning disability, for them to be able to understand their condition and be able to live their life, and secondly, how we could work together to provide additional support to carers of people with chest, heart and stroke conditions. We've got services across the Clyde coast of Scotland.
Thank you, Loretta. Joanne or Chris, are you happy to take that question?
Yeah, I'm happy to come in on that. Thanks, Loretta. And in relation to those with learning disabilities, we are happy to take any referrals for individuals who have one of our conditions, regardless of whether they have learning disabilities or not. We do have a range of healthcare professionals that work on our advice line and across our clinical teams who will have experience of working with those with learning disabilities. And also, I would say what we are very keen to do is take a shared care approach in terms of our management of those individuals. So we would liaise with yourselves, Loretta, around if we felt there was any further expertise that was required to support that individual. So it's very much when referrals come through to us, what we try to do is work with the referring party to ensure that really what we are providing as an organisation is not fully in isolation to other services that they may require. So we do work very closely and collaborate very closely with those organisations and referrers. In terms of carers, it is actually part of our strategy. We recognise that there is much more strain and pressures out there on carers now. And certainly what we are trying to look to see is how we can expand our services and support those individuals to ensure that all our services are not only available for service users or patients, but actually are also available for carers. So befriending services, for example, and we're also running a self-management workshop pilot across the country, and we're looking to see how we can provide some group sessions and some workshops for carers that will complement and run at the same time as those self-management pilots. So effectively, when a patient or service user attends our workshop for 2.5 to 3 hours, the carer then has time to either attend a workshop themselves with us or just have some of that really nice, free, relaxing time for them. We also have a range of health information and education resources for carers now on our website. So I can certainly put some of the links for those into the chat message as well for you.
Thank you, Joanne.
Thank you. Thank you.
We've also got a raised hand from Joanne Elwin. Joanne, would you like to ask your question?
Yes, hi. I'm a staff nurse on the hyperacute stroke ward in Ninewells in Dundee. And my question is about the, you mentioned the statistic that half of the people in Scotland with chest, heart and stroke conditions do not get referred for rehabilitation, and that you're going to increase that over the next few years. Like, is that, can you like, because I'm trying to think, like, if anybody was like needed refer, we would refer them to the stroke liaison service in Dundee when they leave the ward. And I'm like, how is it that, or is that less in stroke, or is it in a particular conditions that that show up in this lack of rehabilitation? Or is stroke quite good for rehabilitation? Because, you know, the way the multidisciplinary team work with rehabilitation and, you know, and the stroke liaison service, I'm thinking, how is it so many people are not accessing the services that are available? But it's probably a very complicated situation. But I was just wondering if that was applicable specifically to stroke as well, that there was a big gap.
Thank you, Joanne.
Do you want me to give the top line, and then if Joanne wants to come in the back? Just to say, Joanne, that's a brilliant question, and you're right that it's complex. And as with anything, the minute you start to dig into it, it gets more complex. So you're absolutely right that across the different conditions, there's different levels of referral into rehabilitation. So there's a difference between pulmonary rehab and cardiac and all the different types of rehab that people could be referred into. Stroke is is one of the stronger areas. I hope I'm not offending anyone in the call by saying that, but we know that there's a clearer pathway for us to see there. So the way that we've constructed the data is to essentially take all the data sets that were published by the Scottish Government. So it's all based on Scottish Government figures. That we've built an overall picture for all of our conditions. And obviously we've got a new condition in terms of long COVID in there, where the pathways are obviously very new and in some places, you know, just really not there yet. So we're taking that into account. The second thing that we look at is what other types of rehabilitation are available. So Scotland has had a strategy around supported self-management for, I mean, over 10 years. It must be almost 15 years now. But there isn't a data set that tells us, you know, who is receiving that and where are they receiving it. And the self-reporting from individuals would tell us that it's around half. So when you put all those data sets together, you come up with a repeating pattern, which is that around half of people are getting referred to some form of rehabilitation. Now, I'm not going to pretend that that is the most perfect data, because it's not. You know, and the discussions that we've had with Jenny Minto, the Minister, around the fact that the data is a jigsaw with lots of gaps, and we accept that. But I think that our feeling was that what we can't do is say that because we don't have the definitive number, that therefore we leave it longer, because that's not really going to help us. And that's why in our strategy, what we've said is we need to define exactly what that gap is and why it is that certain parts of the system aren't being counted. You know, we're not managing to follow through and understand where people are going. But certainly, you know, matching up government data and then matching up the feedback that you get from individuals about their own journeys, that's where we can make that kind of jigsaw and bring that picture together. To be fair, the Scottish Government haven't knocked that figure back, mainly because they can't. They themselves don't have anything that they can give us that is better than the analysis that we've done. But we will work on that to try to define it more. But that's where that comes from.
You're on mute, Joanne.
Sorry. Yeah. Clicking away there. So are there any reasons why? Have you got feedback from individuals or from the services as to why they can't reach them? What are the stumbling blocks, or is that something that you're going to look at in trying to find a solution as well?
Yeah, I mean, there's so many issues. I'm conscious of my time, Joanne. We could probably talk about it over a cup of tea.
Yeah.
I think that there's a range of issues. Some of it is to do with funding and structure, and whether or not there's actually enough capacity and resource to do it. Some of it is about how referrals work. Certainly some of the feedback that we get is that people don't even realise that they've been referred and that they need to pick it up as an individual. So they don't realise at the bottom of the leaflet they were given that was their pathway to that, because it's not made clear enough that that's what they're meant to do. We also hear of people where it's a case of, well, I was told it would be within 6 weeks, but I didn't hear anything like for 3 or 4 months, and then I just didn't, you know, I just thought that was it then. So I think there's a range of issues within the system, and some of it's at the hard end of resource and capacity and having the right structures in place, the right pathways in place. And then there's a whole load of other things going on around communication and engagement and understanding, and whether individuals understand, you know, what that pathway should be for them, and then whether the health service picks it up later on that they didn't get that service, and that's closing the loop, isn't it? And that's sometimes a challenge, I think. But I'm happy if Joanne or anybody else in the call wants to come in on that.
No, I think you've summed it up perfectly, Jane Claire, that there is so many, some small issues and some certainly in relation to resources as well. So yeah, it's really hard to pin it down actually, Joanne, on one reason or one challenge, and I think it would be so much easier for us all if it was. But yeah, certainly the feedback that we are having from service users and patients is it's a whole range of issues, and certainly a whole range of issues that differ sometimes between conditions as well.
Thank you. I don't see any other questions, but there will be opportunity for question and answers at the end of the webinar this morning. So what I would like to do at this point is to stop for a short break. And in Chest, Heart and Stroke Scotland, we like to use the statement, never underestimate the power of a cup of tea. So I would encourage you all to go and get a cup of tea and stretch your legs. And if we can be back by 11:25 to start off with the second part of our webinar. Thank you very much. Welcome back everyone, and I hope you have had the opportunity to grab a cup of tea and stretch your legs. I want to now move on and introduce my colleague Chris Docherty, who is our Community Engagement Coordinator with Chest, Heart and Stroke Scotland, and Chris is going to speak to you today about our Community Healthcare Support Services model. So I'll hand over to Chris. You're on mute, Chris.
What a cracking start that was after Lindsay had been absolutely perfect up until that time. Yeah, thank you everyone for joining us. Really appreciate your time and coming along today. It's greatly appreciated. I suppose the big question here is why do we need a range of services? As Jane Claire alluded to earlier on, if we walk into a room and ask people to put their hands up if anyone's been affected by our conditions, unfortunately, we see hands going up left, right, and centre. Off the back of our survey in 2023, we established that 1 in 5 people in Scotland have one or more of our conditions. I won't read out all the figures you can see on the screen there, but we will be sharing the slides with you after this session. A couple of the biggies to call out for me is that almost 500,000 people in Scotland are living with COPD or asthma. Over 300,000 people are living with coronary heart disease. 136,000 people are living with the impact of stroke. And a new kid on the block for us, 188,000 people are living with long COVID. We also know that almost 1 in 3 have hypertension, which, as we all know, can greatly increase the risk of heart attack, stroke, and heart failure. Now, the need, well, we know the need because, well, the people living with conditions have told us over 500,000 people are not getting the right support and not accessing that first step into supported self-management. We at the charity strongly believe that everyone with our conditions should have access to quality self-supported supported self-management and community recovery service, which is critical to living well with our conditions. I suppose the headline is that people supported by us rate their health and well-being greater than those who don't get our support. And I suppose the question is, why wouldn't we ask to make sure that that number increases across the country? So, as Jane Claire alluded to, with the new strategy comes a new and redesigned service delivery model, our Community Healthcare Support Service, which has a handy acronym of CHSS. They tell us that that was a mistake or a happy accident, but I'll ask you if you believe that as well. It's a model of delivery encompassing the entire journey of those who need our services within the community. It's including 4 strands of delivery, which read top to bottom, our prehab and prevention, our acute event and diagnosis, our at home and in the community, and growing the chain of support. Now, I'll just take you through a little bit more of what those teams look like. Our prehab and prevention is made up of our health defence and health information teams. The aim here is to get in front of our conditions, to work in the community with a strong partnership to deliver health screening, education and support on the ground level. It's to improve knowledge of risk factors, identify early signs and symptoms, tackle health inequalities, to help both individuals and communities across Scotland to live healthier lives. As an example, in Glasgow, our health defence team, which has been performing screening in both Maryhill and Drumchapel, it's working hard with third sector partners to deliver to a wide range of demographics with creditable results. We move on to our acute event diagnosis. Now, underneath this sit our advice line, our health information, education and e-learning teams. For many, this is the first step in accessing the services for both individuals and organisations. Now, the knowledge across this team on our conditions and the barriers and problems that people who have our conditions face is roundly praised by all, and has a real kind of life-changing impacts on those who have connected with it. In my day-to-day role as a community engagement coordinator, I always promote our advice line. It's the first point of contact for our individuals or organisations who support them, and is absolutely vital. Under this strand also we have our resources hub. These are free booklets that can be ordered by anyone in Scotland for free. It includes information that covers all of our conditions. It's available in multiple languages such as Urdu, Punjabi and Polish. The info is also available to access online as well, so that we can save some trees. As well as these, our education and e-learning courses are designed for professionals, and they're acknowledged to be sort of industry leading across the board. We've had some wonderful feedback on some of the courses that have been created, and it's fantastic to hear that feedback too for our team. Move on to the at home and in your community strand. Our clinical community support, physical activity and walking teams are vital in delivering a tailored and personalised approach to support recovery at home and in the community. That ethos of what matters to you being integral to everything that they do. Teams here work directly with service users, offering tailored and personalised approach to recovery on their own journey. It can actually be truly heartwarming to hear the case studies of people supported by these teams. And spoiler alert, you may hear some of that later on today as well. Also within this strand, we have our new chronic disease self-management course, which is coming soon. This is a 6-week supported self-management course. It includes a module on managing your condition, and there's optional activities dependent on the person. Again, it's centered around what their needs are and what matters to them. From studies, it's been shown that this approach can result in benefits such as decreased pain and health distress, increased energy and less fatigue, increased physical activity, decreased depression, better communication with physicians, decreased social role limitations, and increased confidence in managing chronic disease. So absolutely vital for people moving forward. And then we come to the growing of chain of support. We all know that lived experience and the benefits of that sense of community and shared experience is core to growing that chain of support. A large part of this chain are peer groups across the country who are absolutely essential to that continued support in the community. These groups can be the absolute best showcase of the spirit of no life half lived. But we don't want to end the participation there. Everyone who uses our services is an absolute ambassador for the charity, for the services and for that ethos of no life half lived. Who is best to shout with us outside Parliament or to zip line across the Clyde to raise money? I won't be doing that. Or to tell us their stories and experiences of living with one of our conditions and how CHSS has helped them in their journey. And that's our new service delivery model. Talk about it in 10 minutes is an ask, but I welcome people to get in touch and ask more questions. It's a model that delivers at all stages of an individual's journey with their conditions, as part of a Scotland-wide community of colleagues, volunteers, partners, professionals and service users. It's prehab and prevention, it's acute diagnosis, it's at home and in your community, and it's growing that chain of support moving forward. We have a quote here, and again, I won't ask you to squint to see it, but it summarises why we have created this model and what it is hoping to achieve. I'm going to summarise the summary even further in short by saying that we are helping people to look after themselves with support from their communities to live the best life that they can, where they are at the centre, designing and deciding the healthcare that they would like to receive. And finally, of course, partnerships. It's why we're here today, and it's why we want to engage with everyone on this call. With strong, transparent and active partnerships, we can collaborate, we can build, we can deliver across all conditions that we support. And we do this through direct service delivery, trusted and quality signposting, creating strong local, national service delivery, and that peace and participation, support and conversation. We as a charity do this already through partnerships we have, but standing still is moving backwards. So we need to push on. We need to form new relationships, such as the SFA partnership we have. And I'd welcome any of you on the call to get in touch and find out how we can work together, and or how we can evolve any existing partnership to a new level. This would help us make sure that going forward that no life is half lived. And lastly, I'd just like to thank you for your time. Again, a whistle-stop tour, but it's at this point where I say, please get in touch. If there's anything that we can do, I will gladly direct to different departments, etc., as you come in through. But I'll leave you with another little wonderful video from one of our pre-existing partners. And again, thank you for your time today, and look forward to speaking to you in the future. Thanks.
So again, I would just like to extend a thank you to Charlie and Anne-Marie for once again sharing their feedback and experience of working with us in partnership. Now, to move on, we're going to go back to the interactive part and look at another short quiz with you. 2 bits of good news this time. One is there's only 3 questions, and again, the answers will be anonymous. So the questions will appear on your screen. And again, like last time, if you just take a minute to select what you believe to be the correct answer. And these questions are based around the information that you've heard this morning. So we'll start with the first question. So the question 1, how many people in Scotland are living with a chest, heart, stroke or long COVID condition? And the answer is C, 20%. Question 2, who rates their wellbeing higher? People who have used Chest, Heart and Stroke Scotland services or those who haven't? And the answer is A, of course, people who have used our services. And the final question, what services are Chest, Heart and Stroke Scotland delivering in Scotland? And as we've heard throughout this morning's webinar, it is all of the above. So thank you for taking a moment just to submit your responses to the quiz, and hopefully you've managed to select the correct answers. So that now takes us to further time for question and answers. So again, we will unmute you and you can use the raised hand option, or you can pop a question into the chat if you've got anything further that you would like to ask. So we've got one hand up. So Stuart Menzies, would you like to ask a question?
Yeah, thanks very much. I was going to remain muted, but I can never help myself in forums like this. So a quick introduction. I'm Stuart Menzies. I'm a trustee of the charity Sudden Cardiac Arrest UK. Firstly, thanks very much for inviting me along to this. It's been enlightening. It's good to hear the work that Chest, Heart, Stroke Scotland are doing. One area that we've worked hard on, I'd just like to hear what Chest, Heart, Stroke Scotland's taken it, is the term that we apply to the forgotten patient. We've heard a lot about people who have diagnosis, etc., and the work that you're doing with them, but alongside them, there are family members. I will clearly focus on people who have had an out-of-hospital sudden cardiac arrest. There's those who have experienced or been present when traumatic incidents occurred and so on. Those who act as carers, family members, relations, etc. As I say, who we refer to as the forgotten patient, who may also suffer mental health, trauma issues, etc. Is this something that you consider in your strategy to work on? Yeah, probably simple question is that. Is this something that you work with as well? These forgotten patients who they're out there and they're alongside in a very important part supporting the people who have diagnosis. Thank you.
Thank you, Stuart. Joanne or Jane Clare, the focus seems to come to both of you during the questions. Would somebody like to answer the?
I'll make a brief point and then I'll hand over to Joanne, because Stuart, you're spot on, and there's so many different things that we can and should be doing, isn't there? And it's really challenging sometimes to cover them all, and that, we know how much of a challenge that is. I think you're absolutely right. There's a couple of things for us as an organisation. One is reaching people who are undiagnosed, and there is work that we're doing around that. So our community teams are now looking at sort of mobile units that you can go out and start to pick up atrial fibrillation and various different things that allow people to start to manage their health condition, things they don't know about that they have, and then they can start to be supported. And I think you're right. There's a lot of people who are wandering around with signs and symptoms that they might put down to other things as well. You might think I'm breathless, but then that's because I'm now 63 and not 23. So maybe that's why that is. And people aren't necessarily getting the right information to help them with that side of things. So that's definitely something that we look at, both in terms of national policy, but also on the ground. What can we do to contribute towards that? I guess the other thing is making sure that people know that we're here, whether you've got a diagnosis or not. So you can access, our advice line, you can access all of our resources. we're not going to say to you, could you show us your diagnosis from a clinician? That can be really important when it comes to delivering certain parts of our services, because we don't want to do any harm. You don't want to do something that would cause an issue for an individual. But if someone's worried or concerned, they can absolutely come to us for that support, and that might actually start a journey for them. We might be able to give them advice or signpost and help them in that way. So it's certainly in our minds. We're aware that gap is there. But I'm going to hand over to Joanne in case there's more sort of detailed information that she can give you as well. But thank you very much for the question.
Thanks, Jane Claire, and lovely to see you again, Stuart.
Thanks,
So
Joanne,
yes, just in relation to carers and family members and others who may have been affected by conditions but are not directly diagnosed with anything themselves, I think Jane Claire's right. Most of our services are available to everyone, regardless of whether you have a diagnosis. I would say probably that the only services that are not are very specific to our clinical case management services. So that would be the clinical service delivered through a section of our advice line and also our stroke nursing team. But ultimately, those services wouldn't be required for somebody who doesn't have a diagnosis anyway. Our excellent advice line, I've put a link in the chat message just for everybody to go into the website and have a look. But our advice line is open to everybody. Also, our community support services are available to individuals, whether they have a diagnosis or a condition or actually are affected by it. More recently, I know that you and I have had some discussions around out-of-hospital cardiac arrest, particularly in what CHSS and your organisation is doing to support that. We have identified that even in terms of out-of-hospital cardiac arrest, there is very little support for anybody who takes part in CPR. Or has been a bystander. So more recently, we were lucky to receive some funding from the Scottish Government and have developed a service for bystanders of out-of-hospital cardiac arrest. So very much looking to those areas where we feel that we can provide very specific targeted support and provide those services. But I would say that if anybody feels that they would like further support, we are here for those individuals, regardless of whether they have a condition or not.
Thanks very much both for your answers. That's appreciated. Thank you.
Thank you, Joanne. Dr. Gloria Elifouquet, you've got your hand up. Would you like to ask a question? I'm not sure if you can hear me, Gloria.
Okay, can you hear me?
Yeah, I can hear you now. Yeah.
Okay, thank you very much for the presentation. My question is around, I just wondered how many referrals do you get from GPs? I'm one of the GPs, the Grampian MCN stroke lead. So just wondered, are you getting enough referrals from GPs, or is it just self-referral? So that I can pass the information across to my colleagues and see. I know most times when they come out of hospital, they already have the leaflets, and some of them do contact yourself directly. Just wondering, is anything we can do, just to help that? Because I saw the statistics there, deficits there, less people are being referred to the service.
Thank you, Gloria. Joanne, would you like to come in?
Yes, I am happy to answer that. And Amanda Baird, I think we've also got Amanda, who's our lead advice line nurse. So Amanda could probably come in and help me with this one as well. So I would say, to be honest, that most of our referrals are from secondary care. And that is not because we don't wish to receive referrals from primary care and GPs, but that has been more of a challenge. We've worked more recently the last 2 years on a digital pathway, a digital service pathway in NHS Lothian. So it's been a pilot that we've worked on there, particularly over the last 2 years on long COVID, but we are extending that now to stroke. And that is to try and see how we can get direct digital referrals from GP surgeries and from GPs straight into CHSS. And that has been very successful. So I think that the clear challenge for GPs is the time needed to actually refer a patient. And if we can do a one-button referral between two digital systems, the system has worked incredibly well. And if we can do that across the country, then I think it would be hugely beneficial. But certainly the feedback from GPs is that the time that it takes, and sometimes the awareness of what services are out there as well. So we're looking at trying to make sure that we are promoted and marketed across primary care. Our clinical advisor, Dr. Amy Small, is also a GP. And so she's been doing a huge amount of engagement work, but certainly I would always encourage more referrals to come from primary care. That has historically been a challenge for us. And yes, something we're very much trying to focus on. But Amanda, in terms of the referrals that come from GPs to the advice line, you might be able to give a wee bit more detailed information.
Yeah, the numbers are very low from GPs to the advice line. As you said, Joanne, it's mostly secondary care. We do get some from community nurses, but from GPs themselves, it's very low. And I've reached out to a few GPs in Ayrshire, so in the Ayrshire and Arn area, to find out why they're not referring in, because we could lighten the load of your busy work day, especially for things like COPD, etc., where people are phoning for simple questions and taking up a GP's appointment time, where we could absolutely step in and answer that for them. And some of the feedback was, we're referral form, and we're currently looking at that at the moment to see, can we make that easier, because we know that you've got very limited time between appointments to fill in referral forms, etc. And as Joanne said, if we can make it a one-click referral, it would be much easier. But we are more than happy to speak to any GP practice, come in and talk to the nurses, talk to the doctors, because it's an area we really want to get into.
Thank you, Amanda and Joanne. I don't see any other raised hands. So is there any further questions before we move on?
Lindsay, I think there's a question in the Q&A for Chris, I think, from Robert O'Donnell.
Oh, yeah, okay. So hi, Chris. Thanks for your presentation. Do you feel the nature of the ask from people changed over the last few years? And if you do, what do you think is the biggest difference now compared to perhaps when your strategy was first launched?
Yeah, I mean, I don't think there's great question. Thank you for sending that in. I dare say there is. The world has changed quite dramatically over the past few years, and I'm sure everybody's fed up with hearing that that it's changed so much. The ask has definitely changed, and we're looking to adapt to that as much as possible. The charity sort of strongly believes that any services or anything that's offered out to the community has to be designed with the community's feedback in mind. So we're constantly listening to what the community is asking for. There's no doubt about it. Yeah, I mean, I don't know if anybody else has anything to say to that one. Joanne, if you've got anything to add to that.
Yeah, I think in terms of the asks, probably some of, I would maybe go along the route of asks from the NHS. I've done a lot of work with the NHS over the last couple of years, Robert, as well as with your team up in NHS Grampian. And I think certainly some of the asks from our colleagues and other organisations have changed in terms of the pressures are clearly much more significant for other organisations now. So probably the types of things that they're looking for is expanded support, and also clearly what they need to know now to be able to demonstrate the value of services and the value of income that they are putting into services, is that they want to know now a very clear impact of what they're paying for. So if we're delivering a service in NHS Grampian, which is part funded, as an example, then they really need to understand what is the impact on those individuals. And I've seen that significantly change over, I would say, probably the last 4 years, Robert. There's been a huge shift in terms of demonstration of impact. So for me, that's probably one of the biggest things I've noticed since pre-pandemic and now post-pandemic.
Thank you, Joanne. Okay, we're just going to move on because I'm very conscious of time and being able to finish by 12 o'clock. So the last video that I would like to share with you today is our No Life Half Lived film. And I'm sure you'll agree when you watch this film that it really showcases why we're needed, and it highlights the support that we can bring to our service users and people living with our conditions in Scotland. So for those of you that could see the video, I'm sure you'll agree that that was a really lovely way to bring our webinar to a close. However, for those of you that couldn't see it, can I just extend my apologies to you? We have got the link for the film in the chat that I can see, and we'll make sure that that link gets sent round to you because it's a real worthwhile film to watch. So after the webinar, if any of you do have any questions, please do reach out. Chris, our Community Engagement Coordinator, is happy to take your inquiry. His email address is on the slide, but it will also come out with the resources that we will email out to you after the event today. And I would just like to say thank you all for coming along today, and I would like to pass you over to our Chief Executive, Jane Clare, who's going to provide final remarks this morning. Thank you.
Thanks, Lindsay, and thank you so much, everybody, for joining us and giving up your time for this today. I hope it's been really valuable for you, and absolutely want to see any feedback that you've got and any connections that we can make. I just want to really end on one reflection that's really come out of the question that Robert asked around, do we think the nature of asks that people have is different now? And I suppose what I would say is that the overarching journey is not different. Experiencing a condition, getting a diagnosis, going through that acute event, and then coming out of that and feeling the kind of fear and loneliness. I don't think that's changed for people overall. I think that's still there, that people say, I feel worried and I need something post that bit of the journey to help me. I don't think that's changed. What has changed, I think, is the complexity, both for the individuals and for our healthcare colleagues around the table today, our sort of virtual table today. I don't think there's a healthcare professional online who would say things are a bit easier and less complex than they were in 2019. I think we're all in such a different place now. But that complexity, I think, is exactly why working together is so important. It was important pre-pandemic, but it's even more important now, because the complexity in navigating that, the challenge of resources, the challenge of what we're facing in Scotland, it's not necessarily got easier and more simple. So I guess that's my reflection, is the overall journey hasn't changed, but how we tackle it has. And I think in doing that together in partnership, we can really make a difference to the 1 in 5 and make sure that we achieve no life half lived. So thank you very much for today. I hope you've got all the contact details that you need, and we very much look forward to hearing from you if there's things that you think that we can work on together. Thank you.